taking practice. I'll be taking practice question, West Africa, WHCP Station 7, as October 2021, Station 7. The question, please, next slide. Thank you very much. This question reads, a 54-year-old who presented with fever, chest pain, lasting more than 50 minutes, and difficulty breathing. History from wife shows he just returned from India 5 days ago. A non-hypertensive and diabetic, the pain radiated to the back and not to the jaw or shoulders. Had differences in blood pressure from both arms, the right being 170/98 millimeters of mercury and the left 120/90 millimeters of mercury. There was tachycardia with a pulse rate of 108 beats per minute, had a murmur at the right sternal margin and a carotid groove. After stabilizing, he complained of weakness of his left hand grip. He says he has been skipping his medications recently. He still clenches the chest. Question A, what is the differential diagnosis? B, what is the most likely diagnosis from the second information? C, list investigations to rule out differentials. And D, list 4 complications of the condition and which one is present in this patient. Next slide, please. For the differential diagnosis, top on the list will be aortic dissection. Going back to the question, which states that the patient had, there was history of chest pain that lasted more than 15 minutes, though it wasn't giving the description of the chest pain, but it's more like a sudden onset chest pain. For the pain of aortic dissection will be described as most of the time tearing, sharp pain, and also there was look at the examination findings. There was changes, the blood pressure within on the right and the left. It was different, systolic being greater than the differences, especially for the systolic, was more than 20 millimeters of mercury, and there was a significant risk factor, patient being hypertensive. That's bringing the top differential of aortic dissection being top on the list. Other differentials would be we're thinking of sudden onset chest pain, acute pulmonary embolism. This patient is having chest pain. There's history of travel. We just returned from India, so probably there's history of a flight that was have started for some hours. Looking at, say, just returned from India 5 days ago. Then I think that would suffice for bringing acute pulmonary embolism as a very likely differential. Chest pain and the history of being returning from a trip. Acute myocardial infarction, there's chest pain, though not radiating to the jaw or shoulders, but an atypical myocardial infarction can present in that same manner. A very close differential will be looking at an acute pericarditis, an infective endocarditis is also a very close differential for this patient. Why? Being when you look at, there's a fever, this patient had fever. There was also a history of a murmur, though they didn't specify whether it was a new murmur, but it stated that when you have history of fever and new murmur, you always want to suspect an infective endocarditis until proven otherwise. So that's why I brought in also entertain an infective endocarditis as a differential for this patient. And then other differential, acute pancreatitis, the pain is radiating to the back, and patient had risk factor. Patient is diabetic, so acute pancreatitis cannot still be ruled out. So we're looking at other system causes. So looking at a gastrointestinal causes. Acute pancreatitis is a very close differential. Sudden onset chest pain is continuous to pneumothorax, or even a history of a trauma. If he had an accident and there was some form of rib fracture, it can present with severe musculoskeletal pain with some difficulty with breathing, especially when he has maybe flayed chest from a severe traumatic accident. Then that's the last differential I'll mention in this scenario will be because of the history of there's a focal weakness from the last paragraph. There was weakness of the left hand grip. So we want to look at a cerebrovascular disease. Is CVA, patient's been having a CVA. Looking at the heart risk, is hypertensive, is diabetic. Those are risk factors for stroke that patient could have. So the most likely diagnosis is, for the big question, is likely aortic dissection from the reasons which I explained. The significant difference in both blood pressure on the left and the right arm, then the sudden onset chest pain, the sudden onset chest pain, then being hypertensive, and also a murmur. I didn't mention that the murmur that patients would have, it may be a form of maybe an aortic regurgitation, diastolic murmur, which can be like a complication, untoward feature of aortic dissection. So that must tied the diagnosis to being aortic dissection. Now for the C questions, investigations to rule out differentials. Of course, starting with look at blood imaging, and for the blood investigations, baseline, full blood counts. Even if you are trying to do this in all patients, but it's still help you to rule out differentials. The full blood count, where there can be leukocytosis, right? When there's an infective cause, like an infective endocarditis, a blood culture. If you're suspecting an infective endocarditis and you're looking for a likely typical organism, so that may help you to rule out differentials. Then the C-reactive protein will be elevated in most of the inflammatory conditions. D-dimers will be markedly elevated in patients with acute pulmonary embolism. Then troponin for myocardial infarction. Then for the setting of serum amylase and lipase will be elevated in the setting of an acute pancreatitis. Sorry. Lipid profile, blood glucose, glycated hemoglobins, all these investigations. If you're entertaining a stroke, you want to have these investigations done. But notwithstanding, the patient is hypertensive and diabetic, you will still have to do all these investigations in the patient want to ascertain their control, even in the setting of an infective of an aortic dissection. Other investigations for imaging, the ECG, especially in the setting of an MI, where you have your ST segment elevation, or if there's no ST segment elevation, or if you're looking at in some patients with acute with pulmonary embolism, where you have that deep S wave in lead 1, inverted Q wave in 3, inverted T wave in 3, sorry, then Q wave in the 3 as well. Echocardiogram when there are vegetations, especially in setting of infective endocarditis, or okay, of course, you need an echocardiogram to make a diagnosis to want to clinch out the diagnosis of aortic dissection. An abdominal ultrasound scan will also be important, especially in the setting of acute pancreatitis. Then entertaining a CT scan for those when you are suspecting, a cranial brain CT for those expecting for those with stroke patient, for when you are suspecting a CVA stroke. Also a carotid Doppler ultrasound scan will also suffice as well. And for the D question, sorry, please, the next slide. Thank you very much. List 4 complications of this condition and the one that was present. The last part of the question mentioned that the patient there was a murmur, most certainly in when there is an aortic regurgitation. Because of the trauma, there's an baseline, there's a dissection, aortic dissection. You can have some level of a valvular abnormalities in this setting, the aortic valve, so they can be aortic incompetence causing an aortic regurgitation. So this was present in this patient. The patient had a murmur, then weakness and numbness of the digits, especially when you have, of course, there's disruption of the blood supply from depending on the level of the level that the tear is occurring. So you can have paresthesia and numbness of the extremities. It can even get up to the lower limbs, especially when it's involving, when the disruption is also affecting the spinal arteries. This is the setting of a descending, of a descending aortic dissection. I'll talk about in this when I talk about the various classification of aortic dissection. So this was present in the patient. Then you can have a myocardial infarction, of course, when there's a disruption, tearing of the large aorta. If it's affecting the coronary vessels, so you can have blood supply to the heart being affected, and so it can cause an MI. It can be regional or ischemia, depending on the areas of vessels that is affected, then aortic rupture. So I think that's all about the question. I'll just quickly give like a brief overview of aortic dissection. Aortic dissection, following this outline. Thank you. Aortic dissection is a very severe life-threatening disorder that can occur, though it's rare, and is said to arise following separation of the various layers of the aortic wall. There are 3 layers of the aortic wall of the aorta: the adventitia, the intima, and the media. And so aortic dissection this condition is usually associated with very high mortality, and it's said that most of them even die before getting to the accidents and emergency. Next slide, please. Just for the epidemiology, it's said that for the younger patients, there are a couple of risk factors, which I'm going to talk about briefly on the next slide. Younger patients are less likely to have hypertension compared to the older patients, and it can occur within the age of 40 to 70 years. Some can occur between the ages of, most of them occurring between the ages of 50 to 65 years old, just like the case that was talked about, the index case, that the patient was 54 years old. So as regards the risk factors for aortic dissection, top on the list, please next slide, thank you. The risk factors, top on the list is hypertension, which was a risk factor that the patient had. The patient was hypertensive, and he said that he had not been taking his medication. So it's not even worse when the patient has not been taking his or her medications. Then some genetic disorder, like Marfan syndrome, Ehlers-Danlos syndrome has also been implicated as possible risk factors. Even smoking, major trauma can predispose to coming down. Even especially major trauma to the chest specifically can cause some suggested risk factors for aortic dissection. Pregnancy, cocaine use, and certain inflammation of the arteries are possible risk factors for aortic dissection. Then as regards the next slide, please. Thank you. On the classification, so there are various, aortic dissection is classified based on the anatomic location, which is one that is more commonly used by the cardiologist, and there's also can be classified based on how chronic, whether it's acute or chronic. So in terms of chronicity, it's divided into, if it's occurring just within 24 hours, it's classified as hyperacute. When it's with less than 1 week, it's described as acute. Then when it's within a week to 4 weeks, it's said to be subacute. Then it's more than a month, it's being described as a chronic aortic dissection. For the other classification, the more common one is divided into the Stanford system. They use the Stanford system and the DeBakey classification system. The Stanford system is divided into Stanford A and B. And for the Stanford A, it involves I think there's a table, there's a picture out that is usually that will be easier to describe it. Please, can we just go to the there's this picture? Yes, thank you very much. Thank you very much, ma'am. There's this classification. This just sort of summarizes the classification of aortic dissection using the Stanford and the DeBakey classification. So the Stanford is equivalent. Stanford type A is comprises the DeBakey 1 and 2. And the DeBakey 1 is the one that is most common. It's said about 60%, and this involves the ascending aorta, and with or without the aortic arc. Then that's for the DeBakey type 1. Then the DeBakey type 2 classification involves more of the proximal part of the descending aorta as well as the aortic arc, while the DeBakey type 3, which is equivalent to Stanford B classification, involves the whole of the descending aorta. So we're seeing the areas where we have the rupture, or rather the tear. I think that's better. The tear occurring, trying to depict the various differences. They sort of overlap at an extent. But I think the summary is that the most common one occurring type is the DeBakey class type 1, which occurs in 60%, and the least is the DeBakey type 2. And both DeBakey type 1 and 2, they comprise the Stanford A classification system in terms of anatomic location. And just briefly, I will just have to be quick with these slides. It's as regards the pathogenesis, just try to imagine anything that will cause increase in the pressure within this large blood vessel can bring about increased stress and can cause weakening of the wall. So hypertension, the blood pressure is very high, or maybe the patient has a background connective tissue disorder where we already have the result. So anything that causes shear stress on the aortic wall can bring about a rupture. Even just a sudden stress, especially from sudden trauma to the thoracic region, can cause tear within the wall of the aorta, and said that most of these tears tend to occur at the level of the ascending aorta, and usually around the the right and lateral wall. Depending on the extent of damage that occur, it can cause an acute tamponade, or it can even cause an aortic regurgitation. I think that was which now cause the murmurs that patients will present. It can have some form of valvular abnormalities and aortic regurgitation, aortic incompetence, or a rupture can occur as an untoward effect in this in the patient. So depending on the level of the aortic, the level of tear, that will not bring about the clinical presentation that they will present with. So the common sites of aortic dissection include when nearly around 2 to 2.5 cm above the aortic root. This is said to be the most common site. I think I mentioned that's just trying to depict where you have that debarcate type 1, 60% occurring. The other area is just distal to the origin of the left subclavian artery and also at the level of the aortic arc. Our next slide, this is just trying to give us a pictorial view of blood penetrating the intima and entering the medial layer. So it sort of gives this picture of a force aneurysm. Of a force. So it's not because the tear does not involve the entire 3 layers. So that's more like a force aneurysm also. But when it involves the entire 3 layers, so that's more like a true dissection. And for the clinical features, they will present with sudden onset severe chest pain, usually described as tearing or ripping in quality. It can radiate to the back, and they can have this they can have this neck or jaw pain depending if it's affecting depending on the vessel involvement. So when it's involving the descending aorta, they can have this intracapsular pain. Then it's very important that some patients may not come down with pain at all, and this is usually seen in about less than 10% of patients. Other clinical features that they can present with can be, you can have hemiparesis, hemiplegia, especially when it's involving the spinal descending aorta. There's affectation of the spinal arteries, or they can have abdominal pain if the abdominal aorta is affected, and they can have this anxiety or feeling of impending doom, having this premonition of death wanting to occur. And next slide, please. The clinical features that they will present with, they can have hypertension, so they have this blood pressure difference, just like the clinical case scenario that was painted. Interarm blood pressure difference being greater than 20 millimeters of mercury. When you just have that and you see that, you'll be wanting to suspect an aortic dissection. So when there is aortic incompetence, so they can have aortic regurgitation, so you can have a murmurs, which this patient presented with. Then if there's cardiac tamponade, you can have muffled out sound and hypotension. Then depending on if the coronary, they can have altered mental status, and they can have a diastolic murmur as other clinical features. Next slide will be, thank you very much. Okay, I've talked about differential diagnosis, so I'll not mention this anymore. For the investigation, basically, ECG and HSS will just help us to rule out other causes of to want to find out, to differentiate other causes of chest pain. But sometimes it may not really be clear cut, because you can have some of the other causes of chest pain being present in the patient that has aortic dissection. So, but for the chest X-ray findings, please can go to the next slide. I think I have a picture for chest X-ray, a typical chest X-ray that will show there is widening. You have there is this left apical cap. There can be pleural effusion. They will have deviation of the esophagus. Then there's also loss of the paratracheal strip. So I think this is just a typical view of a chest X-ray of a patient that has aortic dissection. So also to our next slide, and the next slide, please. So just to mention that if you have a patient is stable, like the tear is not so much and the patient is stable, patient can have a CT scan. CT scan with contrast can be done, and suggestive features that can show on CT, they can have intimal dissection flap, double lumen, aortic dilatation, hematoma. Then they can have contrast leak can indicate an aortic rupture. As regards echo is usually the preferred technique. Some have said a CT Transesophageal echo is the preferred technique and usually can be done at the bedside, but usually the experience of the operator is very, very important in having to carry out this procedure. Then there's also another investigation, CT orthography is also what can actually be done. This is a picture of showing a typical echo finding, a typical echogram showing the true lumen and the false lumen of an aortic dissection. You know, I mentioned when there's a true lumen, there's more like a rupture and transversing the entire three layers. Then a false lumen, when just maybe like a tear from the inner layer, from the adventitia, the outer layer, going into, you now have blood seeping into the media. So it now sort of creates a false lumen. So this is just giving a picture. If we can see, maybe eventually when we zoom, we can look at that later on to see the color flow. The second one is just trying to show the color flow through the lumen of in a patient that has aortic dissection. And please, the next slide. I think my time is almost up. So I think I talked about the echo findings already. And this is a CT, a typical chest CT showing a descending aortic dissection. So you're having the tear at the level of the aorta. So this is just at various view. I think the first one is at the transverse view. You should look at the area that is circled with red, shows the aorta, the descending aorta that's dissected, and this is vertical, a vertical view that's trying to give us more like a more a better view of the dissected aorta in the thoracic region. So then for the others, for treatments, treatment basically can be, so most of the time, surgical. It can be surgical or medical. So usually, of course, this is where you involve the vascular surgeons, and they can resect or replace the dissected aorta using a graft. Most of it, they replace it with a Dacron graft, and said that emergency surgical correction is the preferred treatment for the fallen, especially for Stanford type A. Now said that includes the Barclay type 1 and 2, is ascending aorta dissection complicated by Stanford type B, with specific clinical radiologic evidence of a number of conditions, which would include, please can get on to the next slide, which also may include if there is an increasing diameter of the area that is being told, there's increasing the size of the hematoma. So basically, a patient that is having the aortic dissection is massive, and there is affectation of major branches of the aorta. So that those are also indications for emergency surgical repair to be done alongside other indication. Patients having persistent pain despite having the patient's morphine, are giving adequate analgesia. So possible contraindications: if the patient is having a CVA, there's sudden neurological deficit, patient is having a stroke, or the patient is pregnant, or there's a history of a myocardial infarction just less than 6 months ago, or the patient is elderly, and we've realized that the risk actually outweighs the benefits, and setting up other comorbidities, and enough to, this patient may not benefit from having surgery. Patient is having arrhythmias, which which is actually said to be a contraindication to surgery. Sorry, next slide, please.
So
okay,
just round up. I think we're
okay. Thank you very much. Thank you very much, sir. Thank you, sir.
Yeah.
The treatment option used the beta blockers, such as alabetalo and the others, to use for the patient. And complications of aortic dissection, I mentioned the one that was present to the patient. The patient had there was weakness that the patient had. They can have an aortic incompetence, where like the index case I was talked about, aortic regurgitation. So they can have diastolic murmur. They can have multi-organ failure, especially when the various branches of the aorta are being affected. They can have an MI if you are having around the region of the descending aorta. So they can have hypoperfusion of the kidney. So they can have renal failure. and it can be patients is being predisposed to having a recurrent dissection. And when the dissection is massive, it can ultimately lead to death. Follow up for the patients. It's very important that you want to monitor strict blood pressure control is key. And it's important to know that most of the patients that present to the accident and emergency prognosis here, it presents to most of them even die before getting to the accidents and emergency. Thank you very much for listening.
All right. Thank you, Dr. Ruli, for a wonderful presentation. So quickly entertain contribution comments. Okay, Dr. Tanimo, you can go ahead and make your contribution.
Thank you very much for this presentation. It's a very good one. But when you are arranging your investigations to rule out diagnosis, you have to start with the most important ones. The most important ones here is echocardiography, ECG, and chest X-ray. This because you should not start with full blood count, which may not help you very much. But if you start with echocardiography, ECG, and chest X-ray, are the most important ones that you have your diagnosis, and you rule out other diagnoses. Let's say echocardiography, you can rule out MI. You can also rule in the dissecting aortic aneurysm. You can also rule out pericardial tamponade, all those things. Also ECG and chest X-ray. In the chest X-ray, you will see the medicinal increase in the medicinal something like that. So that is it. So the important ones, you have to bring the important ones before the less important ones, because of even time again. And also can COVID-19 be a differential? Because especially in that period of time when the question was set. Thank you very much, but it's a very good one.
Thank you, sir.
Thank you, Dr. Tanimo. Any other contribution? Okay, let me read from the chat box. Okay, Dr. Success said, well done for your presentation. Dr. Ishoma said, CT, yes.
Dr.
Hello?
I thought
Yes,
Dr. Tanimo asked a question. I don't know. He asked if COVID is a differential here. I don't know if the participant.
Okay, I wanted to. Okay.
Yeah. Hello, sir.
Yes, we can hear you.
Yes, sir. I think COVID can be a differential, because I remember we're talking about it as a complication of COVID infection. The patient is being at risk of coming down with an infective endocarditis, and we can have some form of vegetations that can predispose the patient. So I suspect, I'm not so sure, I'll be open to correction. I suspect COVID-19 can be a differential, as more like a complication.
Okay. Does anybody have any other views as regards to this? Okay, while we're waiting, let me just read out the comments here. So Dr. Mosope said, you seem to investigate all your differentials and not your most likely diagnosis. Okay, I think Dr. Tanimo mentioned something like that. So in which case, CT aortography and the likes should have come first. Okay. Are there infective causes of aortic dissection? So that's his question, Mosope. He's saying echocardiography is better for type A aortic dissection. So he's saying, are there infective causes of aortic dissection? Then Dr. Victor said, remember to group and cross-match at least 10 units of blood on standby. Yeah. Okay, Dr. Ekele. Okay, just uploading. So the two questions here is, the question here is, are there infective causes of aortic dissection?
Thank you very much. As regards the infective causes, I really think what I came across was more like risk factors. We mentioned connective tissue disorders and others, like when But I didn't come across specific infective causes that was mentioned. They just talked about risk factors, the connective tissue disorders, the Marfan syndrome, Ehlers-Danlos syndrome, then pregnancy, cooking. Those are not really infective causes. So I really didn't come across that because.
Okay, Dr. Mosope, do you have an answer to that?
Well, thank you. Well done, Ma, for your presentation. I think syphilis, syphilitic hepatitis can be a possible cause. And then I was also thinking in the line of the person that asked about whether COVID could be a cause, especially given the fact, I mean, it could be a risk factor, especially given the fact that this patient traveled and had fever prior the onset of the other symptoms. And I was thinking that the time when the question was set, it may be possible that COVID should also have been considered. So thank you.
Okay, thank you very much, sir. Thank you, sir.
Thank you. Dr. Eke, please, can you help us share Dr. Balogun's slide where we are still entertaining contributions? Okay. Okay. Dr. Esther is saying transesophageal echo. Is it a bedside procedure?
About it depends on if the person that can, if there's a if the cardiologist is available to carry out the procedure, is something.
No,
but the patient is actually
she's asking, is it a bedside? I think you mentioned something like a bedside,
yes,
something that you can
it
do
will be a
bedside
procedure if the person to do it is available at that time. I think that was where that clause of if the challenge is having somebody that can carry out the transesophageal echo, because the machines are really not bulky, as in the newer ones are really not bulky.
Okay. Then Dr. Kocha says aortic stenosis is a differential.
Hello, I think it will be more of an aortic regurgitation. Likely more of an aortic regurgitation, not aortic stenosis.
Okay. So any other further contributions before we go to our next question?
Good morning, my sisters and colleagues.
Yeah, good morning.
I just want to say something, maybe because of the question the person said concerning. Thank you so much for your presentation. It was detailed, it was nice. I think you did a good job. Then to add to it, I just wanted to add that just like they said, the CT aortography is important. Then transesophageal echo in Nigeria is not a bedside procedure. It has to be done. Most times we need to take the person into the echo room and all of that. It's not something we do on the ward for our patients in Nigeria. And then thirdly, because of the person that said aortic stenosis, usually both arms of the upper limb, both arms, the difference in blood pressure should not be more than 10 mmHg. Then between the upper limb and the lower limb, it shouldn't be more than 20. The lower limbs have higher blood pressure measurement. So when you have a disparity in the blood pressure measurement, that's when you begin to think of other causes. So apart from aortic dissection, if you have a subvalvular aortic stenosis, you can have that difference in blood pressure. If you have coarctation of the aorta, if you have atherosclerosis of the subclavian artery on one side, you can also have that difference in blood pressure. So not just only aortic dissection. So these are other causes of the difference in blood pressure on both arms. When it's more than 10 mmHg, then it's significant. Thank you.
Thank you, Ma.
Okay. Good morning, everyone. Thank you so much for your detailed presentation. You did excellently well. I just want to add just one contribution. Okay, so as regards patients with COVID-19 and the heart, in COVID-19, there's a lot of inflammatory process ongoing. So it was discovered that patients who came down with COVID-19 had an inflammatory process going on in the aorta, thereby predisposing them to an aneurysm. And having an aortic aneurysm increases the risk of tear in the aortic lining, which can cause a dissection. So in a patient who has aortic dissection, COVID-19 can actually cause dissection, like it can be a complication in this patients, because they realized that patients who had COVID-19 came down more with aortic aneurysm as compared to those who did not have. And then aortic aneurysm can predispose to it, yeah, which will lead to aortic dissection. So yes, that's what I have to say about COVID-19 and the aorta. Thank you.
All right, yeah, thank you, Dr. Florence, for a wonderful contribution. Okay, so Dr. Kocha is saying regurgitation will come with wide pulse pressure. Dr. Kopi say we do bedside echo. You're just referring to what Dr. Chineme just mentioned. So they are portable echoes now. Cool. Any other contribution? Please, can you put it on slide share or slideshow? Sorry, so that it's just down your right, the right bottom. Bring your cursor to the right bottom of your screen. Who is helping out to share this slide?
I don't know. I'm not the one sharing. Am I the one sharing?
No, I don't think you're the one. So I don't know who is sharing this slide, please. Hello, Dr. Balogun. Dr. Balogun, can you hear? That's the classic again.
Okay, good morning. I tried sharing myself. Let me try again, please. It's okay. Good morning. Can you hear me?
Yes, we can hear
Okay,
you.
good morning. Let me try again. Thank you. Can you see my slide now?
No, we cannot see it yet.
Okay, Dr. Kalapi, can you help me share? Thank you.
Recording in progress.
Wait, can I still be heard? Good morning.
Yeah,
Can
you
you
can
hear
be
me?
heard.
Good morning.
Yeah, morning, we can hear you.
Okay, sorry. Let me just go back to the meeting. Can I start? Good morning.
Yeah, you can start.
Good morning. My name is Dr. Balogun. I'm taking October 2021 General Medicine Recall number 6. And the question goes thus. A 75-year-old non-hypertensive with back pain and CA prostate visited the hypertension clinic, and the doctor added another medication. He presented with lip swelling and difficulty in breathing. There's a picture was shown. It says, what is the diagnosis? B, mention 4 classes of drugs that can cause it. And then C, how would you manage this patient? The diagnosis in this case is angioedema, and specifically because of the history that was given. It was mentioned that the patient went to hypertensive clinic, so it's fairly much to conclude that he was given antihypertensive. And the most notorious for angioedema is are the ACE inhibitors. So diagnosis in this case would be ACE angiotensin converting enzyme inhibitor induced angioedema. That's for the diagnosis. Then the B part. It says mention 4 classes of drugs that can cause it. So I said 1, the ACE inhibitors are notorious for this. Like I said, most times 8% of cases of angioedema from drugs is from ACE inhibitors. Other causes include your DPP4 inhibitors, the recombinant tissue plasminogen activators, your direct renin inhibitors, NSAIDs, SSRIs, and then exogenous estrogen. Then to manage this patient, diagnosis many times is clinical. So in this instance, in this index patient, we have a history of drug. And in this case, we're assuming that it's an ACE inhibitor. from the history that we gathered. So it's usually clinical. You have a history, quickly take a quick history as in most cases. Then you want to make you want to examine your patients. In this case, it was said that he had lip swelling and then he had difficulty in breathing. As in most cases of adverse drug reaction, you want to discontinue the offending drug. In this case, like I said earlier, an ACE inhibitor. The principal focus is airway management, and multidisciplinary approach should be employed. You want to inform the ICU, you want to tell the ENT surgeons, and in some cases, the pulmonologist and then allergic specialist. Focus, like I said, is airway management. So you want to examine the patient. Is laryngeal obstruction, is it very severe? In which case, you might have to intubate the patient, and in extreme cases, a tracheostomy might be done. Now, note that steroids and epinephrine have limited role in these patients, and we'll explain as we go further down the presentation. Fresh frozen plasma should be given to these patients, and if the symptoms persist, you want to repeat this. Another drug of importance is the incatibant. It's a bradykinin B2 receptor antagonist, and we'll explain the mode of action as we go further down in the presentation. Of what you have noticed also that you want to prevent a secondary prevention. You want to ensure that you don't test the patient. You don't want to give the patient the same drug, because a patient that's had this adverse reaction to an ACE inhibitor would obviously again have the same reaction. And this, in the next instance, it might be worse. So secondary prevention is very important. You want to counsel the patient and the relatives not to give the same class of drug, and note that it's a class effect, meaning that if the patient reacts to one ACE inhibitor, it would likely react to other ACE inhibitor in the same class. That's that for the question. Now to the overview of the of angioedema. Sorry. Overview. So it's said to be localized subcutaneous tissue and on submucosal tissue edema. Usually is well circumscribed and is asymmetrical. It usually involves the lips, the face, the neck, oral cavity, and the guts. It is termed life-threatening if it affects the larynx, as in this case. And then you should note that guts involvement patient might present as acute abdomen. Temporal profile usually is from few hours to 3 days. Other causes of angioedema would include allergens like food, drugs, and insect bites, radio contrast media, NSAIDs and aspirin, anaphylaxis. Also in many cases, idiopathic, maybe histamine-induced or bradykinin-induced, as I would explain later on. And then it might be hereditary or acquired. Classification based on pathology, this is very important, but this has a bearing on how patients might present and how you would eventually manage the patient. Pathophysiologically, it could be histamine-induced or bradykinin-induced. Histamine angioedema is a type 1 hypersensitive reaction. It's acute, many times hyperacute, and is a commoner type, mediated by mast cells and basophil release, and it leads to increased vascular permeability and plasma extravasation, and ultimately angioedema. The bradykinin-induced angioedema, which is in this case, this index patient, which is what this index patient has, is also called a non-histamine mediated angioedema. And in this case, it is mediated by the kallikrein, by the kinin-kallikrein cascade. I'll explain with this slide. So the initiator is H-man factor 12, H-man factor 12, which is H-man factor, which gets activated when it comes to contact with tissue. Now, pre-kallikrein itself is inactive. It becomes proteolyzed by this activated factor 12, to kallikrein. More proteolysis and becomes high molecular weight kininogen. With more proteolysis, with further proteolysis, it becomes bradykinin, which is, in this case, is the offending agent. Now, normally in the body, under normal homeostasis, bradykinin is degraded by an AC, angiotensin converting enzyme. This abounds in the body, but more so in the lungs. Now, when you give the AC inhibitor, you pharmacologically inhibit this action, meaning that AC at this point will not work. Bradykinin would then accumulate in the system. It binds onto bradykinin B12 receptor, and then exerts its action. Bradykinin, as we know, is a very potent vasodilator. So there's vasodilation, there's extravasation of fluid, and ultimately angioedema, as in this patient. Now, what you have noticed, it's important to differentiate between histaminergic and bradykinin-induced angioedema, because, like I said earlier, it has that would determine how you would manage your patients. So in differentiating both of them, histaminergic angioedema, many times is hyperacute within minutes to hours. So the patient comes in, maybe he's taking granite and allergic to granite. Within minutes, patient has this angioedema. However, in bradykinin, slower effect and slower onset from hours to as long as 3 days. I should mention that for ACE inhibitors causing angioedema, many times the adverse effect is seen within one week of commencing patient on medication. However, in rare instances, it could take as long as 30 days. And in at the extreme, at times 1 year, you could have started patient on the antihypertensives and then comes down with this angioedema 1 year. It becomes difficult to tease out this. But note that, like I said earlier, slower onset. Then for histaminergic, many times the reaction is brief, while for bradykinin-induced is longer. They have fluid features of anaphylaxis in histaminergic. Patient is healing, it has it's wheezing, it has wheals, it has hives, it can be hypotensive. But many times for bradykinin-induced, they usually don't have urticaria, they don't have hives. They just come with the angioedema and they might have complaint of abdominal symptoms, which is not so common in histaminergic angioedema. Then response to antihistamines and steroids is very good with histaminergic, while in bradykinin-induced, you don't have response, have very poor or no response to antihistamines and steroids. Hence, it is important to differentiate them when instituting your management. Mortality for histaminergics is low, while for bradykinin-induced angioedema, mortality is usually very high as 15% in some cases if management is not instituted early. I just give another overview. Types of angioedema, like I said, histamine-mediated or bradykinin-mediated. And then note that bradykinin-mediated can be acquired, as in this case, or can be hereditary. Overall approach to the patients with angioedema. I don't see it so well. Sorry. Yeah, so tiny in my phone. Oh, sorry. Sorry, I can't see too well on my phone, so let me just open from my. So overall approach. Pardon me. Sorry.
So you can enlarge the picture.
Trying to on my phone. It's not on my laptop, rather. It's not enlarging. Okay.
Oh, okay.
Trying to enlarge. Sorry, it's so tiny, I can barely make anything out of it. Well, I can get, okay, so it says, okay, so patient comes to the emergency room. You're not exactly sure if it's, okay, like I said, it's clinical. Patient comes, he has edema, face, lips, swollen, patient has stride. Okay, thank you. So patient comes to the emergency room and then he has features of angioedema. Like I said, it's clinical. So his face is swollen, lips are swollen, patient has stridor, and you suspect angioedema. The first thing you want to, like I said, you've called the ENT surgeons, you've called the ICU, you've alerted ICU. The ENT surgeon goes ahead to do a nasolaryngoscopy or bronchoscopy, and then if it's seen to be severe laryngeal edema, they want to intubate and then treat the patient as critical as he is. But if you see that, if it's found that the patient does not need immediate intubation, you want to determine, is it histamine or bradykinin-mediated angioedema? Many times you might have a history, as in this case, and you can guess that is, and you can know of a certainty that is bradykinin-mediated. But in the instance that you're not sure if it's histamine or bradykinin-mediated angioedema, what to do, because histamine is the more common one, is to treat the patient along the line of histamine-induced angioedema. And what to do, you want to give patient IM or IV epinephrine, 0.5 milligrams if it's IM, or 5 to 15 micrograms per minute infusion if it's IV. This can be repeated if there's no resolution of symptoms. At the same time, I want to give IV methylprednisolone, 125 milligrams starts, and then the antihistamine, 50 milligrams IV. You also want to give the patient PPIs. And if the symptoms resolve, then we're happy. However, if symptoms persist, then you can hazard a guess that it most likely bradykinin-mediated. And what to do in this instance, you want to give 1 gram tranexamic acid IV. And then if it's ACE-induced, as in this patient, you consider fresh frozen plasma. You can remember the kinin kallikrein cascade I showed earlier. It says that fresh frozen plasma would act on the bradykinin itself and will help to mop up the bradykinin. It helps to, it hastens the metabolism of bradykinin. While ecantibart actually acts on the bradykinin B2 receptor. It's said to be very expensive. It's giving us 3 mils 3 mL subcutaneously for over 30 minutes, and it can be repeated if patient doesn't have respite. So in conclusion, angioedema is rather rare, but it can be life-threatening, and it's important to differentiate the different pathological types promptly as treatment varies. Thank you.
Dr. Balogun.
Yes, please.
Yeah, thank you, Dr. Balogun, for a wonderful presentation. Okay, so it's time for comments, contributions, questions, clarifications. So Dr. Momodu is saying, how can we differentiate angioedema, anaphylaxis, and anaphylactoid reaction? And then secondly, he said, is there a role of serum tryptase in angioedema?
Okay. Thanks for the question. So he mentioned, he said, how do you differentiate angioedema from anaphylaxis? And anaphylaxis might present as angioedema. Like I said, if it's histaminagic type 1 acute hypersensitivity reaction, can present as an angioedema. The difference is to differentiate between histamine-mediated and bradykinin-mediated. Frankly, I'm not sure what an anaphylactoid reaction will be and how to differentiate it.
Is there a role of serum type? Yeah.
Hello?
Yes, please.
Let me just contribute to that question.
Thank you.
Yeah, anaphylaxis is usually like the most severe form of angioedema, okay? Where you have systemic involved most of the time, okay? Unlike the localized one that happens in angioedema. Okay. So, for example, the person has hypertension and that's gone beyond angioedema. That's usually the way to differentiate. Okay. Now, for anaphylaxis and anaphylactoid, we have actually stopped using the term anaphylactoid reactions. Okay, so anaphylactoid and anaphylactic reactions are forms of anaphylaxis. Okay, so anaphylaxis is IgE mediated, anaphylactoid is non-IgE mediated. Okay, so, but people, since they are treated the same way, they present similarly, people no longer talk about anaphylactic, just anaphylaxis. Okay.
Thank you. Yes, thank you.
Thank you very much, sir. Thank you very much, sir. So is there a role of serum tryptase in angioedema? That is the second question I asked.
I didn't find, when I was doing my research, I didn't find serum tryptase as being used. Yes.
Dr. Momodu, if you have anything to say about it, then you can go ahead. And then Dr. Ekela is asking, is there a place for antihistamine in the management?
For bradykinin mediated, no. It's been found that it has no role whatsoever. It's not effective. But if you are sure it's histamine mediated, then you can use your antihistamine and then steroids, anti-inflammatory. But because of the pathophysiology that we mentioned earlier, antihistamines have no role for bradykinin induced or mediated angioedema as in this patient.
Okay. All right, thank you. Any other contribution, Dr. Momodu? Did you find anything on serum tryptase in angioedema so that you can
Okay, good morning, teachers. Good morning. Typically, sometimes when all these reactions occur, it might be actually difficult to actually denote whether it's anaphylaxis or from an anaphylactic cause. So serum tryptase can help. Most times when we see raised serum tryptase, which may suggest an allergic cause of the angioedema. Okay, and when it's persistent, mostly greater than 7 nanogram or something like that, there's what they call it, the tryptase elevation may also indicates a mast cell abnormality or disorder. Thank you.
All right, thank you. Any other contributions, comments, clarifications?
I have a question.
Okay.
Okay, thank you very much for your presentation. I observed that from what you explained, when it's ACEI induced angioedema, is likely the bradykinin pathway. And from what you explained, antihistamines should not be used. Now, I know we had answered this question sometime in the past, and part of the treatment that was included in that question answering was that IV antihistamines like diphenhydramine can be used. And I'm wondering now if what you're saying is the proper thing. How do we answer? Because the way you answered yours is slightly different from the way it was answered the other time. Please, can we throw light on this?
Like I
Hello?
said earlier,
Hello?
Andrew.
Sorry. Yeah. Can you guys hear me?
Yes.
Yes, we can hear you, sir.
So I'm not aware we've answered this question before. I think the one we answered was someone thought it was angioedema, but the diagnosis was more anaphylaxis. So the one that the person answered was an anaphylaxis. I don't think it was. No, that was the. Is it? There's one. What do you call them again? This antibody. What do you call biologics? Which one is it? Is it rituximab or so? Rituximab induced anaphylaxis. I think that's the one we answered. Let's not mix it up.
Yes, sir. I think that, yeah,
Oh,
that's what we answered the last time.
yeah, so let's not mix it up. I think it was rituximab induced anaphylaxis we answered, not this particular one. This one is quite classical. That particular one, the patient actually had hypertension too. I think the BP was 80, 60 or something like that. So that was more of an anaphylaxis. This one is obviously ACI induced angioedema. If you notice, the question was straightforward. He didn't even talk about any systemic involvement. He just said swollen lips and what's the other thing again that the patient presented in this particular case. This is classical angioedema. Okay, so, and if it is bradykinin induced, then you don't really need histamine. It's only when you are not sure that you can give antihistamine. I think she already answered the question. Thank you.
Yeah, thank you, sir, for the contribution.
We have answered this
Any
thing
other?
before.
So, any other contribution?
Sorry, sir. I just wanted to ask that question, please, as part of the answers for differentiating anaphylaxis and angioedema, because the person answered that angioedema is a severe form of anaphylaxis, or so I really couldn't get that statement well. I'll need clarification, please.
Anaphylaxis is severer than angioedema. Anaphylaxis is a severer form. Okay, some people think it's a spectrum from angioedema to anaphylaxis.
Okay,
so it's
sir.
usually when there's systemic involvement, that's when it is anaphylaxis.
Okay,
However,
sir.
when it is still localized, that in this patient, it's more likely to be angioedema.
Thank you so much, sir. Thank you, sir.
Yeah. Thank you very much, sir, for the contribution. Any other comments? Any other? Okay. We'll hand over to Dr. Christabel and our teachers to close the class.
Thank you. Thank you, Dr. Atta. I hope I can be heard clearly.
It can be heard.
Okay. Thank you so much. Thank you. It was quite an interactive session. I appreciate the participants, those that help us share Dr. Kele Robert, the two presenters, you guys did well. I want to notice the second presenter. She kept to time. She finished before time. The first presenter did well, quite a lucid presentation, but we need to work on your time management. The exam, we don't have so much time. move on to stuff. And that's one of the things we encourage in this class.